Let me wish you all a very, very happy International Women's Day, and it's my proud privilege to speak about the pregnancy and the cyanotic heart disease. Of course, it may be little very too high for you people, but Jyotsna said that, however, to complete we have to cover this. So, women born with the congenital cyanotic heart disease who mature into childbearing years are exposed to the risk of pregnancy. In order to improve the outcomes of women with the cyanotic congenital heart disease, the risk stratification is recommended even before pregnancy. See, after becoming pregnant, that's different, but before pregnancy itself, the counseling has to be done. But unfortunately, many people in our country, they do not come to you until they become pregnant. But however, all the cyanotic congenital heart patients must be well informed about the risk of the pregnancy in them. There are at least 7 changes during the pregnancy which are related to cardiovascular changes, and all are very important. The heart position and the size, the blood volume, the blood pressure, the systemic vascular resistance, stroke volume, cardiac output, heart murmur and blood flow are all altered during the pregnancy. And all these changes are troublesome for unhealthy women, especially those who have got an underlying cyanotic congenital heart disease. There may be an increase in the right to left shunt with the subsequent increase in the cyanosis, and which can prove very, very detrimental to the fetus as well as the mother. So, if a young pregnant woman with the cyanotic congenital heart disease comes with the difficulty of breathing as a chief complaint, then the first thing that one must determine is whether it is a physiological or a pathological, that she has got anemia and and any pregnant woman will be breathless. So first thing you have to find out is whether it is physiological or pathological, because physiological dyspnea can occur in pregnant women as a result of the uterus which is enlarged, which is pushing the diaphragm and all those things. But however, dyspnea with the severe enough to limit her routine activity, and then during the pregnancy, that has to be taken very, very seriously, and she has to be evaluated. European Society of Cardiology and some literature have shown that anyone with the NYHA class 3 or 4 symptoms is highly recommended for termination of pregnancy. If they are in class 3 or 4, it will be risk for the mother to continue. So such patients, the termination of pregnancy is indicated. However, pregnancy can proceed with the total bed rest and supportive care if the risk is less. If patient chooses to continue with pregnancy, then the next thing to be discussed are items which are needed to be monitored during pregnancy. One is the labor, delivery, post-paturation, as well as, because without optimal management, the prognosis of pregnancy in these patients with the uncorrected cyanotic congenital heart disease is extremely poor. Embryogenesis, fetal growth and the survival of the perinatal period depends on the optimal maternal health and the normal placental development. Failure of the normal placental function may have profound both acute as well as the chronic effect on the developing fetus and leading to IUGR like the previous case. So that has to be kept in mind. So as already our honorable chairperson mentioned earlier, and when whenever the saturation is less than 85, you can see that the live births are very, very less. And when the saturation is more than 90, the live birth is much better. So the cutoff is the saturation. If the saturation is less than 85, risk to the fetus is very high. If it is between 85 to 95, it is medium, but more than 90, it is much safer for the fetus. So cyanosis women with an oxygen saturation of less than 85 at rest should be advised against pregnancy. That is class 3C indication, and the risk of the maternal complication is almost 30%. So So remember, the cutoff is 85. Less than 85, it is risk for both mother as well as the fetus. So hemoglobin high due to the low SO2, anemia in this subset of patients exaggerates hypoxemia, right to left shunt, and then it worsens the spontaneous abortion, DVT, paradoxical embolization, as well as platelet aggregation and risk of thrombus formation. And the strokes are all because of the bad combination of cyanosis with anemia, and that is very, very important. The effects of hypoxemia on the fetus are failure of the fetus to achieve its genetically determined growth potential. About 10% of all these babies grow poorly in utero and are born small in the gestational age. IUGR is associated with the distress and asphyxia and a 6 to 10 fold increase in the perinatal mortality. So remember that somebody has to be there, a neonatologist, to tackle these problems in the once the fetus is born. Acute and chronic hypoxemia is also associated with a variety of morphological, functional, fetal cardiac changes, and these are extremely important. Hypoxemia sensitizes the chemoreceptors, leading to the breathlessness. If patient is in NYHA class 3 or 4, then will be unable to do even the simple activity like having bath or getting dressed. So all these phenomena are felt appropriate with the reduction in the peripheral vascular resistance, with increasing maternal hypoxia as reflected by the mother's increase in the hemoglobin and decrease in the maternal oxygen saturation, the percentage of life-born infants falls, and that is very important. The effect of neonate in newborn has the risk of apnea as a result of intrauterine asphyxia. Therefore, despite routine observation every 15 minutes for the first active phase of delivery and every 5 minutes for the second phase of delivery, the American College of Obstetricians and Gynecologists have recommended that the doctor should assist the delivery and, if needed, has optimal neonatal resuscitation ability. A person with that ability must be there. Otherwise, having gone through the whole pregnancy, at the end, the result will be empty, and that will be very disastrous to the mother. In addition to the routine obstetrics observation, one must observe blood gas analysis, especially PO2 and SO2. And in fetus, two things to be monitored are the fetal growth and the well-being. These can be done by the regular uterine fundal height measurements and Doppler velocities, cardio thing, and the fetal heart, placenta, dynamic functions. All these things now the echocardiographers are so well versed, and all this data can come, and if required, the cesarean section is indicated only for the obstetrical indication and not because of the cyanotic congenital heart disease the mother has got. Now, vaginal versus cesarean section. The reasons are bleeding amount that theoretically will be lesser if vaginal birth mode is chosen. 400 to 500 cc compared to the 800 to 1000 cc when the surgery is done. If cesarean section is indicated, general anesthesia is chosen to avoid the hypotensive effect of regionally administered anesthetic drugs, and administration of massive loading fluid before procedure is recommended to avoid the hypotensive effect, possibly because hypertension and then polycythemia together, the stroke is also very high. So during the delivery, the first phase of delivery, it is recommended to avoid the usage of iatrogenic agents, although some suggest that the usage of low dose of epidural analgesia for reducing the oxygen consumption. There is about two group of thoughts also. The patient is recommended to take left lateral decubitus position to prevent the spine hypotensive syndrome of pregnancy, because the gravid uterus will compress the inferior vena cava, so the venous return will come down and the preload will be less. In second phase of delivery, the forceps usage is recommended, but nowadays, the forceps itself, they have got their own thing. And the third phase of delivery, it is recommended to limit the bleeding amount, and the patient, especially with the NYHA class 3 or 4 is recommended to give breastfeeding considering the hypotensive effect of the oxytocin which is produced during the breastfeeding process. So SB prophylaxis, as we earlier discussed, another problem to be considered in infective endocarditis risk during delivery process. American Heart Association categorizes, but in our country, 2 gram of ampicillin given intravenously and 1.5 gram per kg body weight gentamicin 30 minutes before the procedure, the surgery, and that is very important. And unrepaired cyanotic congenital heart disease, interestingly, unrepaired or palliated cyanotic CHD does not belong to the high risk group, and this rate decreases 10 to 15% if the maternal oxygen saturation drops below 85%. So here, cyanotic congenital heart disease, unrepaired defects including tricuspid atresia, detransposition of great arteries, tetralogy of Fallot with pulmonary atresia, univentricular heart, all of them severe pulmonary hypertension, severe systemic ventricular dysfunction, and pregnancy is contraindicated. Pregnancy is contraindicated in Eisenmenger syndrome. Any woman with the Eisenmengers, you do not allow them to become pregnant. So pregnancy outcome in Epstein's anomaly, no serious pregnancy related maternal complications like maternal death or the stroke or congestive heart failure, arrhythmias or endocarditis occur. But however, the fetal wastage is quite high. Incidence is around 6%, and here the even the fetal Epstein anomaly can be made out. So in symptomatic patients with Epstein's anomaly with the cyanotic and the heart failure should be treated before pregnancy and advised against pregnancy. Tell them in advance that this is not going to be good for your fetus as well as for your own self. Do not go for the pregnancy. The closure of the PFO or AST should be considered if the patient is at a higher risk, and like the previous case, if associated PDA is there, that also can be closed so that the pulmonary hypertension can be brought down. Now, congenital corrected transposition of great arteries with VST and pulmonary stenosis causing cyanosis, what is the risk for the mother and the fetus? So echocardiography, we have made the diagnosis. The maternal functional capacity and cyanosis are the major risk factors for miscarriage. So fetal wastage is higher between 16 to 27% compared to the average for the other patients. So incidence of congenital heart disease for this mother, her child is anywhere between 2 to 18. So you have to warn them and then do the fetal echocardiography for the fetus. So pregnancy in women with the corrected transposition of great artery, no maternal deaths were reported in some series. However, women with the significant systemic ventricular dysfunction, severe tricuspid regurgitation should be advised against the pregnancy because this can be deleterious for both mother as well as the fetus. So this is a 28 years old lady with the 16 weeks dysfunction, presented with the history of exertional breathlessness and easy fatigability, and echo showed a large subaortic VST with the double chambered RV, and because of that increased RV pressure there was a cyanosis in her. How risky is the pregnancy in her? So once we have evaluated the gradient as well as this thing, and here you can see that she also had a non-compaction of the left ventricle which is going to worsen her pump failure. So patient has non-compaction and then has got a risk of thromboembolism and 3 arrhythmia, 4 severe RVOT obstruction due to the double chambered RV in presence of the large VST. It increases the right to left shunt, especially during the delivery, and then the cyanosis is likely to become worse, so one has to be careful. The trilogy of Fallot, 30 years old lady, with the 8 months amenorrhea, history of easy fatigability, breathlessness, severe cyanosis and clubbing. Saturation is only 72. I told you that when the saturation is less than 85, it is very, very difficult. So emergency balloon valvoplasty was done to reduce the risk to the fetus as well as to the mother, and then only when the saturation improved to 90, and then it was the patient was delivered. So is this patient at any risk of cardiac or the non-cardiac complications during pregnancy, labor, delivery, yes or no? Then here we have to do the emergency balloon valvoplasty to see that the risk to the mother as well as the fetus are reduced. Now, natural history of tetralogy of Fallot, very few patients with the present as without correction of the tetralogy of Fallot. Most of the children are undergoing surgery now because the surgical results are so good, and pregnancy is well tolerated in women who had undergone the surgical correction. However, the tetralogy of Fallot is one of the most common cyanotic conditions where more than 7 to 10% of the congenital heart disease malformations occur. If any cyanotic woman comes in the childbearing age, make the diagnosis of tetralogy, you're likely to be right because that is the commonest one. Now, tetralogy of Fallot is very important cause of maternal morbidity. It's almost 62.5% and even mortality up to 10%, and have a significant effects on the fetal outcome. Therefore, knowledge about the maternal cardiovascular physiology changes all are important for the obstetricians. In repaired tetralogy of Fallot, the risk of pregnancy depends on the degree of the residual hemodynamic impairment, whether there is RVOT obstruction is still present or not. And here you can see that the outcome depends on the prepartum NYHA functional class. If they are in class 1, class 2, no problem. But if they are in class 3 or class 4, because of the absent pulmonary valve or the RV dysfunction, those patients will have a higher morbidity. The incidence of congenital heart disease is higher in fetus which mother has a tetralogy. If mother has a tetralogy, the child which is going to be born will have anywhere between 5 to 6% higher. So echocardiography at the 22 weeks gestation is very important, and these are the patients with the tetralogy increase. Yeah, I'll just finish. So ventricular arrhythmias are the ones which have to be kept in mind. They can have deleterious effects, and I'll just skip because the time is thing. This is a 28 years old lady undergone surgery, but with the pregnancy she came with the failure. Here you can see that instead of the AR occurring in the RV, it was LV, it was occurring in the AR. So with such a severe aortic regurgitation in RV, she came with the congestive cardiac failure, and these are all very, very high risk. So post-operative, even whatever the residual morbidity is left, that is also important. This is the 32 years old lady with the tetralogy of Fallot with pulmonary atresia and lots of MAPCAs, multiple the surgical repair. And is she fit for conceive? The answer is no. So the Fontan operation, the patients born with the complex defects cannot be repaired to increase the two ventricular circulation, commonly undergo a series of operations to create a Fontan correction. And these, after the Fontan operation, the systemic venous blood return directly to the pulmonary arteries, and the functional single ventricle supplies both the systemic and the pulmonary circulation in series. And in these patients, they frequently do well for many years, but during pregnancy they have very high risk. So even in mothers with a good Fontan, miscarriage rates are extremely high, and then the failure embolic complications are high. So pregnancy in women with the Fontan operation must be undertaken with the great deliberation, discuss and talk to them, explain to them, and then only they allow. And anyone with this sort of thing, this is a 20 years old lady, already LV dysfunction is there, tricuspid atresia and pericardial effusion has occurred, and saturation is 47. The answer is clearly no to the pregnancy, because both it is risk to the mother as well as the fetus. So preconception counseling for all women with the pre-existing cardiac condition must have preconception counseling. But however, in our country, though this is not the right one, see, she had almost 178 gradient across the aortic valve, and we raised the funds and did the balloon dilatation. She underwent the cesarean section, and then she disappeared, and she reappeared only after 1.5 years when she was pregnant again. So in our country, the situation is so bad that early counseling is extremely important, but extremely difficult in our country. And hence, whatever Jyotsna is conducting to bring the awareness among the women is very important, because they have to reach the hospital, reach the doctor in time for the counseling to understand the significant underlying thing. The medical records are very important, and the past history is also important, and echocardiography plays an important role in making the precise diagnosis. So the maternal evaluation as well as the fetal evaluation are extremely important, and ultimately it is the awareness in the public that is very important. And thank you very much for your kind and the patient hearing. Thank you.
Thank you, Dr. Vijayalakshmi, for your such a nice, lucid and elaborate talk on management of cyanotic heart disease. And ladies and gentlemen, I think she needs a standing ovation on this International Women's Day for all the achievements she has to her credit.
Thank you so much. I'm so much touched by your humility and kindness. Thank you very much.